My name is Andrea Millers with Endogastric Solutions, and I have the great pleasure of being here today with Dr. Kenneth Chang. He is the Executive Director of H.H. Chow Comprehensive Digestive Disease Center at University of California, Irvine. He's also the Professor and Chief Division of Gastroenterology and Hepatology. So welcome, Dr. Chang, and thank you for being here today.
Thank you, Andrea.
Thank you. We also have the great pleasure of having one of Dr. Chang's patients, Jaime Martinez. So welcome, and thank you for being here today with us.
Thank you, Andrea.
Can't wait to hear about your story. We're going to go ahead and start. So Dr. Chang, if you could please kind of talk to us a little bit about what is GERD or what is acid reflux?
Sure, Andrea. So GERD stands for gastroesophageal reflux disease, and maybe I can demonstrate on a little model.
That'd be fantastic.
I carry my esophagus everywhere I go.
I love that. Thank you, Dr. Chang.
So this is the esophagus, which brings food from the mouth to the stomach, and here is the top of the stomach. And the stomach, as we know, makes a lot of acid to help with food digestion. And there's a natural barrier to keep that acid from splashing up into the esophagus. This is called the lower esophageal sphincter. And it's a smart valve which allows food to enter the stomach when it's moving down the esophagus with peristalsis. But it should remain closed to prevent acid and food from splashing back up. So GERD happens when that mechanism fails, and all of that acid, sometimes bile, food and liquid, splashes up into the esophagus. And these can cause symptoms, and they can also cause health consequences. The typical symptoms of GERD include heartburn, this sensation of burning behind the sternum. Also regurgitation, the real sense of fluid and sometimes food coming back up into the back of the throat.
Right.
And we call those the typical symptoms.
Sure.
There are also atypical symptoms, symptoms that are not related to the esophagus per se, where patients may wind up in the ENT doctor's office or the pulmonologist's office, and they include symptoms such as cough, chronic cough, throat irritation, throat clearing, the sense of having a lump in the throat, shortness of breath, asthma, wheezing, can also be what we call atypical manifestations of GERD or acid reflux. And sometimes those patients go kind of around the block to different specialists until finally someone says, oh, this may be acid reflux or GERD, and then they come and see us. So those are the symptoms of GERD, and then there are the health consequences.
Sure.
Patients can have ulcers and inflammation of the esophagus. We call that esophagitis. Mm-hmm. That can result with stricture or scarring and tightening of the esophagus so that food no longer can pass through.
Right.
And precancerous changes, the cells that line the esophagus can morph into these precancerous cells, which we call Barrett's esophagus, and that can lead to esophageal cancer, which alarmingly is the fastest growing cancer in the United States, more than an 8-fold increase over the last 25, 30 years. So very much GERD can lead to Barrett's, which can lead to cancer. So those are the consequences of GERD.
Right. Thank you for your explanation, Dr. Chang. That was great. Jaime, why don't you kind of tell us your story? I know we talked earlier and you said you were suffering for over 20 years. That's correct? And
Yes.
tell us a little bit about the symptoms that you were feeling and how it affected your life.
Well, Dr. Chang described a lot of them. I've been at this for 20 to 22 years, and it started with the sensation of the acid, feeling hot stomach. As time went by, it started to go and travel up to the throat,
right,
to the sinuses. Funny that you mentioned the ear, nose, and throat. I ended up with one of those doctors.
Okay.
I had to have sinus surgery from the amount of acid I had, and I guess it located there. So all of these things through the years were happening to me. The pressure, the asthma, I think I had the whole gambit as I searched for an answer.
Wow,
So 20 years.
Mhm.
Wow.
that's incredible. So, were there different lifestyle changes that you had to do, or foods you had to avoid because of the acid reflux?
Through the visits with doctors, gastroenterologists, you start to find out that certain foods affect your life in different ways with your stomach and with the reflux. So you start cutting out things, experimenting to see what they do. You cut out caffeine, you cut out sodas, you cut out chocolate, fried foods. There's a myriad of spicy foods. There's just a myriad of things you have to cut out, reduce to very bland food, which becomes, of course, your life.
Right.
And then I think we mentioned this before, that when you go to a nice dinner with people, you're pretty much having to not eat like everybody else does. So
Quality of life,
right.
right?
So
Quality of life.
it changes everything you do.
Wow, wow. So, Dr. Chang, can you please tell us, what do you recommend patients that are suffering with GERD? How do they manage their acid reflux and GERD symptoms?
Yeah, we always start off with a more or less stepwise approach to treating GERD.
Sure.
The first would be lifestyle modifications, as Jaime very nicely described. We talk about smaller amounts of food, taking more frequently through the day, but avoiding eating close to bedtime. Certain foods can cause that valve to loosen. Caffeine, alcohol, sweets, fatty foods tend to loosen the valve as well. So certain foods to avoid. Patients who are overweight, losing weight can go a long way also in helping decrease reflux, but
Sure.
losing weight is not as easy as it sounds. So there's modifications from diet. There's also modifications in how we sleep. I think, Jaime, you had trouble with sleep.
Right.
And a lot of patients say, they can't get a good night's sleep. They can't sleep flat on the bed without having significant regurgitation, cough, waking them up, choking, and so on.
Right.
So then we recommend elevating the head of the bed, and that's either a hospital bed or putting the bed up on actually cinder
Stilts,
blocks
okay.
or stilts, raising the bed so that there's gravity helping the acid from going uphill.
Right.
So we do that first. That's always our first line. But soon after that, we start looking at medications to block or neutralize the acid. So the most common and most prescribed medications are the proton pump inhibitors, or
Right.
PPI medications.
Sure.
Those are the omeprazole, Prilosec, Protonix, Prevacid, Dexilant, Nexium. All of these medicines are effective in neutralizing
Right.
the acid in the stomach.
Okay.
So it does that quite well, and patients will typically respond. They'll say, "Hey, the less burning in the esophagus," but it doesn't change the mechanics. It doesn't change the fact that fluid is still splashing up into the esophagus or the throat. So the regurgitation part oftentimes is not responding to the medications per se.
Okay.
So about 75-80% of patients do quite well just on the medication.
Sure.
But then there are a lot of patients who are not fully responding to medications, or do not wish to be on these medications for life.
Right.
So they're looking for other alternatives.
Right.
And that's when we look at endoscopic procedures that can help strengthen the valve, as well as surgery that can help create a barrier to acid reflux.
Okay. So I know, since you were suffering for 20 years, right, you had mentioned to me that you were actually on PPIs for
Yes.
a very long time, and there finally came to a point where you had enough. I don't want to take PPIs anymore. Tell us a little bit about that, and what made you decide. Were there concerns about taking the PPIs? And maybe Dr. Chang, you can kind of educate us a little bit more, because there's a lot of news and press releases that are out there talking about PPIs and the effects of long-term PPIs. maybe you can kind of demyth some of it, and then also give us, educate us on what the truth is.
I'd love to hear, Jaime,
Yeah.
what were your concerns about
Well,
these medications?
I was on the PPIs, but my issue with the PPIs, of course, were the side effects. But while on the PPIs, I still was seeking out baking soda, Tums, Rolaids, because I wasn't getting the total effect that I was looking for.
Okay.
Right.
The cough would not disappear, the asthma would still happen, and so forth. So the side effect concerns were more to bone denigration, depletion of vitamin B12,
Yes.
and also the dementia that was a result in dementia for long-term usage.
Right.
So those are the motivating factors for me to look for solutions to try to mitigate the fact that I needed to take those pills.
Yeah, so there's, my clinic is literally full of patients coming in with a real concern for these medications. And, every newspaper, every magazine will usually feature some concern
Right.
about these medications. There are some real things that have been shown to be a direct cause of these medications. Long-term use of PPI can reduce in lowering magnesium level, which sometimes can be important. B12 levels certainly can be lowered as well in patients on chronic PPIs. PPIs can also alter your biome, your GI gut flora, and so patients can have diarrhea. There can be increased Clostridium difficile, which is an organism that can arise and cause diarrhea because of the change in the gut biome.
Okay.
So those have been shown because of the absorption issue. Certain forms of calcium may be inhibited by acid blockade in the stomach, and that could result in a decrease in bone density. So that is a plausible causal relationship. Certainly we know that epidemiologic studies have shown that there is an association
Sure.
between PPI use and hip fractures. Again, we get to the issue of studies that show an association
Mhm.
and studies that show a cause and
Cause,
effect.
Yeah.
There are very few cause and effect things that we can blame directly on the medicines.
Okay.
There have been a number of studies looking at this association.
Okay.
For example, there was initially a real concern that folks who are on these medicines had an increased risk of dementia versus those who are not.
Right.
But then subsequent studies showed that that association was not correlated.
Okay.
So we don't feel that that really has much weight. There's been studies that showed people who are on PPIs are more likely to die, mortality. So that would certainly make everyone
Sure.
concerned.
Sure.
But the study did say that generalizability. These are for older white men, and so whether that's generalizable or not. And also, there's the real issue of what's called a confounding variable. There may be something about people who are on PPIs that we haven't identified, and maybe this is a sicker group than those who are not.
Interesting.
So a lot of the other associations are there, but they're merely associations. It
Sure.
makes us want to look into that further,
Right.
but that's different than to say this
Will
pill
cause.
will give you dementia,
Right.
or this pill will hurt your kidneys.
Right.
There's a rare, kidney injury that can happen, but the chronic kidney issue is right now an epidemiologic association, which still has not proven a cause effect.
Okay.
So this is an area still of
Sure.
controversy. There's a lot more research being done in this area, but I will tell you that there's enough concern for patients to say, these medicines, and for doctors,
Sure.
these medicines may not be as safe as we once thought.
Right.
And so if there's a way to get off of these medicines, we certainly want to explore that.
Yeah.
In the past, you had really only two buckets of choices. You can stay on these medicines, or you can have an operation or surgery.
Right.
And a lot of times that was just too much of a leap for patients.
Right.
But now we're filling that
Gap.
option gap
Right.
with some of the
The
new
new technology.
technologies.
Right. And this is a perfect segue to start talking about the TIF procedure. But before we do that, I think we do have a question from Facebook. So, Lynn?
We do. We have a question from Mark. He says, I have LPR reflux, and my doctor has ordered a 24-hour pH off of medication, manometry, and a gastric emptying study. Is this sufficient for a consultation for the TIF procedure?
That's a great question, Mark. So yes, with LPR symptoms, which are more in the atypical, whether it's cough or throat clearance and so on, a lot of these symptoms can be caused by other things. So usually the ear, nose, throat doctor will look in and see some redness or inflammation and say, oh, this may be related to GERD. And so the workup then would involve an endoscopy to look and see anatomically if the valve is loose or not. Usually a pH study, and the pH study now the most sophisticated pH study is a wireless capsule that can be attached to the inside lining of the esophagus, and that's designed to stay there for 48 hours and measure minute by minute how much acid is coming up into the esophagus. And it sends that wirelessly to a little receiver that you wear like the size of a pager. And that little pill then drops and goes out through the digestive process, and you don't have to go look for it. And then the receiver is brought back to the physician, and then we can analyze and see, okay, during that 48 hours, you coughed at midnight and you coughed at 5 a.m. and during that cough episode, we see there was active acid reflux, and that gives us the much higher certainty that your cough is from acid reflux and not from postnasal drip. Once we have that confirmation, then we're going to go down the treatment trail towards something more definitive to help the symptoms. So I think the workup that you've been recommended, Mark, is very appropriate. The manometry, which is a through the nose catheter that measures how well the esophagus is squeezing, we call that peristalsis, is necessary if you're eventually going to go to surgery. But for the endoscopic treatments such as TIF, that is not necessary, especially if the patient is not describing symptoms of dysphagia, which means trouble getting food down or trouble with swallowing. So the recommended approach is very good.
Thank you. Thank you very much for answering that, Dr. Chang. Can you, let's talk about the TIF procedure and the other, you mentioned the gap, right, between taking PPIs and the Nissen fundoplication, and that there's other procedures now or new technology in between, obviously TIF procedure. Can you talk a little bit about the different options that are available now that we all know about?
Yeah. So let's go on the surgical side of things.
Yes, please.
So the standard procedure that has been available for decades now is the Nissen fundoplication, which is actually a 3-part procedure surgically.
Sure.
So the surgeon will make 5 keyhole incisions in the abdomen, advance the instrument. Part 1 of the surgery is if there's a hiatal hernia, which means, you can take my model out, if part of the stomach has protruded and herniated up above the diaphragm, this is the diaphragm muscles, and if the diaphragm muscles weaken and split apart, part of the stomach can come up, and we call that a hiatal hernia.
Right.
So part 1 is reduce the hernia, which simply means pull it back down where it belongs. Part 2 is if the diaphragm muscles have split apart, the surgeons can then repair that by putting sutures and like a necktie, tighten it tighter against the esophagus.
Right.
That's part 2.
Okay.
And part 3 is the wrap, which means the surgeon would take the stomach, free it up from some of the blood vessels, and then wrap the stomach around the esophagus like a bath towel wrapped around my shoulders. If my shoulders is the esophagus and the bath towel is my stomach, I would wrap that tight and suture all that down. So it's a 3-part procedure, and that's the Nissen fundoplication.
Okay.
Efficacy is quite high.
Mm-hmm.
Durability is 8 to 10 years, not forever.
Okay.
And there are some side effects, and so this is what patients don't like about that procedure. There's about 20% chance that the patient will have trouble with not being able to vomit, not being able to belch or burp or vent the stomach.
Right.
And then that can result in what's called a gas bloat syndrome, where they feel their abdomen is distended like a drum because they can't vent and get that air out.
Right.
So that can be quite uncomfortable for patients. And so that has been a drawback to the standard surgery.
Okay.
Then there's the LINX procedure or LINX device. This is augmentation of the valve. So part 1 and part 2 is very similar to the Nissen fundoplication. If there's a hernia, that's reduced. If the diaphragm muscles need some reinforcement, that's tightened. And part 3, instead of the wrap part, the surgeon will place a ring of magnets around the esophagus, almost like a bracelet. And these magnets attract each other and create a tightening. And so food can pass through because the food has enough pressure to move the magnets apart, but acid coming from the stomach cannot mount enough force to push the magnets apart. So it's a bit of a one-way valve,
Right.
which is quite ingenious.
Okay.
The obvious upside of that is, unlike body tissue that's used to wrap around like the bath towel around the shoulders, over time, like many of our body parts, we can get loose over time, and the Nissen fundoplication can get loose over time. Earth magnets are less likely to loosen over time, so we feel that the durability of the magnets would be longer.
Okay.
The drawback is you've got a ring of magnets around the esophagus. There's a very small percentage of patients who can have movement or erosion of the device. And then there is the issue of MRI, because an MRI is a very strong magnet, and under the very strong magnet, there's the possibility of demagnetizing the earth magnets of the device. That's at the higher Tesla 3.0. So there's concern about future need for MRIs for patients, and so that's the upside downside of the LINX procedure.
Okay.
Then there's some variation. There are some surgeons now who offer, instead of the full 360 Nissen fundoplication wrap,
Sure.
there's also, you can do a partial wrap.
Okay.
So there's the door procedure, and there's the toupee procedure, which does a partial wrap.
And there's less side effects if they do it that way.
Slightly less gas bloat, and so decrease some of the
Side
side
effects.
effects. Yeah.
Okay.
So those are the main surgical options for patients suffering from GERD.
Okay.
And then now there are also available the endoscopic, which means no surgery. There's the strata radiofrequency, which is these small needle electrodes that go to strengthen the valve. But that's really in patients who have a valve to begin with. A lot of patients, their valve is quite loose, and they really need a mechanical tightening as opposed to stimulating the muscle to be more robust.
Okay.
So that leads really to the TIF procedure.
Sure.
TIF stands for transoral by mouth.
Right.
The I is incisionless, no cutting.
Yeah.
The F is fundoplication, creating that valve. So again, on this model, if I can show the concept of TIF. So without surgery, we have a endoscopic device that goes in while the patient is under sedation. It's under general anesthesia. Imagine here a loose valve, and imagine if I can go inside and grab these two corners and essentially pull them down, almost like an extension of the esophagus down into the stomach, creating almost like the end of a funnel, or we call that a flap valve. By doing that, what happens is that food has no trouble sliding down, but because of the length and the angling of that new funnel or extension, acid has a harder time going up.
Right.
So that's really the concept behind the TIF procedure. Typically, it takes about 35 minutes, 40 minutes, so it's a relatively short procedure. It's again done not in the operating room. It can be done in an outpatient setting, and patients typically recover. When they wake up, they may have a bit of a sore throat, some discomfort where we created the new valve. We do like to keep the patients in extended observation, so we either do an overnight 23-hour observation or a 6 to 8 hour observation, depending on how the patient's doing.
Okay.
And then the patient goes home, and we start clear liquids almost immediately. Then we go to full liquids and puree. So within 2 to 3 weeks, they're actually back on a fairly normal diet.
Right.
So we advance it faster than someone who's undergone surgery.
Right. Now, remind me, you've done over 100?
Well over 100 of these
TIF procedures,
yes.
right? And something I want to bring up too, Jaime, you actually were first originally going to get the LINX procedure, right?
Right, that's correct.
So you got your workup for getting the LINX procedure, and then you ended up switching over and meeting Dr. Chang
Yes.
and having the TIF procedure. Do you want to kind of share your story, or what
Well,
happened?
I did have the workup for the LINX procedure, and LINX was not covered by Medicare or any supplemental insurance. Plus, also it's incisions that you have to go through. So that to me was kind of a drawback. I found out about Dr. Chang through the UCI publication, where it explained the TIF procedure, which is non-invasive and much easier on the body and much faster on the recuperation. So that's where I seeked out to come here and line up and get my TIF.
Right.
And Medicare covers it. But supplemental covered what Medicare did not cover. So it was kind of a smart solution for me to follow.
Fantastic. And from what I hear, and we'll ask you a little bit more about this, that you're very happy because you had your procedure, it's been 3 months now in February?
About 3 months, February 22nd.
So, and you said your protocol, Dr. Chang, for post-op is, how long are they on some sort of, when do they start introducing, normal foods after they've had the procedure?
Yeah, we give some guiding principles, and there's some flexibility.
Sure.
But we immediately start with clear liquids and go to full liquids within 2-3 days.
Okay.
And then if the patient's tolerating the full liquids, and full liquids is protein shakes and smoothies and so on.
Okay.
Then they go to a more soft puree diet.
Okay.
And then they go to scrambled eggs and pastas and so on. And then by week 2-3, if they're doing well, they can start with regular solid food.
So,
Jaime, what was your progression?
That was basically my experience, except that I extended it by 2 or 3 days on each face.
Okay.
Just because that's me. So by the third week, I was with the soft eggs and so I was getting back to the normal.
Great.
And so let's talk about some foods that you can eat now that you were not able to eat before, or even activities. I know you mentioned that you love to road bike, play racquetball. Tell us a little bit about what that was like before, and then now that after having the TIF procedure, how has that changed it for you?
Well, with the exercise, with the GERD, it would have side effects of pressure on the chest, the stomach, regurgitation at certain points of the exercise, especially with the biking, with racquetball, with the bending and all that stuff, a lot of coughing and stuff like that. Those, I'm not biking anymore, but I am playing racquetball quite frequently, 3 or 4 times a week, and I'm not having any of the side effects I was having before, the cough and all of those things, or even the asthma.
So you can get through the game and beat your opponent.
Well, not necessarily beat the opponent, but get through the game. And I will play for an hour and a half to 2.
Wow.
So it's demanding, but I don't have a side effect.
And that's with staying on these PPI medicines or not?
No, I've been clear of the PPIs now for 3 weeks.
Nice.
Not one has touched my lips, and I haven't had any acid reflux for that period, well, since the operation, really.
Tell me how you're sleeping.
Last night, 8 hours straight, no, not a problem. Laying down
Love
totally flat.
Wow, that's tremendous.
Tremendous.
So it's life is normal, so to speak.
Life is better, right?
Yes.
No more suffering anymore, right?
To this point is fantastic.
That is wonderful. That's wonderful to hear. I believe we have another question from Facebook.
We do. Will a TIF procedure fix my hiatal hernia?
That's an excellent question. So just in case you didn't hear it, the question was, will the TIF procedure fix my hiatal hernia? So it's a yes and no. Yes, if your hiatal hernia is 2 centimeters or less. No, if it's larger than that. And let me go over that again. This is a very important point and question. Remember we talked about the lower esophageal sphincter, the valve. That's the inside valve, and the diaphragm, you can almost think of the diaphragm wrapping around the esophagus as your second valve, the outside valve. If that second valve, outside valve, is really loose and the stomach is coming up quite a bit into the chest, that hernia, there's no way currently that we can reduce all of that with an endoscopic procedure. To pull the stomach down and then to tighten and repair the diaphragm muscles, we cannot do that currently internally. Maybe give us a few more years, but not now.
Right.
So in patients who have a weak internal valve and have a hernia that's less than 2 centimeters, they're still a very good candidate for the TIF procedure, and they're not too far along the spectrum of GERD. But if you've got a 3, 4, 5 centimeter hiatal hernia, that definitely requires surgery to bring the stomach down and to tighten the diaphragm. Now, there is now also a growing number of patients who say, okay, great, I'll have surgery for those 2 parts,
Right.
but I really don't want to have that wrap. Can you do the TIF
Thank you.
and create a valve
Right.
as part 3? And the answer is yes. That is an FDA-approved indication for the TIF procedure. We call that a concomitant procedure, where the surgery is done and the TIF is done for part 3.
Right.
That can be done in the hands of a single surgeon doing part 1, 2, and 3, which includes TIF as number 3,
Right.
or a combined effort from the surgeon and a gastroenterologist like myself, who will come in and do part 3. So we're doing that on a regular basis here at UCI, where I partner with my surgical colleagues. We have 4 amazing foregut surgeons who can do part 1 and 2, and I come in and do part 3. Patients do really well because they don't get the full wrap. There's still some issues with links, whether a payment issue or an MRI issue. And doing the TIF as part 3 actually makes sense for a lot of patients.
Fantastic. Wonderful. We have another question. Thank you. That's a great explanation. I like the 1, 2, 3 step, the way that you explain that, because it makes it very clear to understand that you need to fix everything, right? Sometimes,
yes.
Right.
The last question I have from the audience is, if I don't live in your area, how do I find a doctor who does the TIF procedure in my area?
Great. So there is a website. It's called GERDhelp.com.
Yep.
Am I right?
Yeah, you're right. That's good.
Yeah.
Yes.
So you go to GERDhelp.com, and then you can click on your geographic area, and it should list the physicians in your area who are for the TIF procedure.
Fantastic. And if you're in the Orange County or Irvine area, you can
Come
come
to
and
see
see
me.
Dr. Chang and his
Be
group.
honored to help.
Fantastic. Well, is there anything else that you'd like to share with us today or with the Facebook users, either Dr. Chang or Jaime, about your experience with the TIF procedure?
Well, the only thing I would say is don't let it go on too long. 20 years of doing this was not a lot of fun, so seek, be your own advocate, go for it.
I love that. I love that. Thank you very much. And Dr. Chang, any final words?
That was the
how do
great-
you top that?
I can't top that, Jaime.
Can't top
well
that.
said.
Thank you.
Yeah.
Well, thank you again, Facebook users, for coming to our TIF talk. We really appreciate it, and thank you again to Dr. Chang and to Jaime for being here today. If you guys ever want to learn more about acid reflux and GERD, please visit gerdhelp.com. There's a lot of information on there, a lot what Dr. Chang explained, and some patient testimonials as well. And as he mentioned, if you're looking for a physician in your area, you can find a physician in your local area through the physician finder. So thank you again for joining us, and we'll catch you next time.